Over the next few weeks, you will focus on a population of choice and you'll begin working on a health promotion proposal that will work on improving health outcomes in that specific population. When we talk about health promotion programs, we're really looking to identify a gap, a something that's missing, or a negative health impact, and develop a strategy to address it and improve population health for a community or a specific subsegment of a population. When we're doing health promotion programs, it's very important that we consider the community and the culture that we're working with in order to make sure that whatever activities we have planned will be accepted, and we will then change health behaviors and impact the community in a positive way. Before we move ahead and learn more about health program planning, we need to make sure that everybody understands the difference between health and wellness. Health is the greatest of human blessings, as defined by the father of medicine, Hippocrates. The World Health Organization actually further defined health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Wellness, on the other hand, is actually an active process through which people become aware of and make choices toward a more successful existence. There are many dimensions of wellness. Some models say 6 and some models say 8. The models that say 8 add finance and the environment as dimensions of somebody's wellness. All models agree that our occupational or vocational wellness, our intellectual wellness, our financial wellness, our social wellness, our emotional, spiritual, and physical wellness all go towards our overall well-being. And our overall well-being impacts our health outcomes. So when we're doing health program planning or health education, or we're trying to improve the health outcome of a population, it's really important that we consider all these dimensions and aspects in order to really move the dial on health. In more recent decades, the social determinants of health that we learned about previously have become an increasingly useful paradigm to portray the multidimensionality of health. When we consider developing a health program to improve the health of a community, we're often looking at a health behavior change. We need everybody to understand how complex it is to change somebody's health behavior. An example is you have somebody that's smoking. How do you get that person to move towards the healthier behavior of not smoking and not using tobacco? It's very complex and it can be individualistic. It often involves a multi-stage process. Most people agree on the trans-theoretical or change model in terms of how people move towards a positive health behavior change. When we're talking about the change model, there are 5 stages. The first is pre-contemplation. It actually reveals unmotivated people who see no need to find a solution to a problem because they usually do not believe that one exists. Next is contemplation. This stage is marked by awareness and acknowledgement of the problematic behavior with serious consideration to change. However, the person is uncertain if the problem behavior is worthy of correcting. The next stage is preparation. At this point in the change process, the person can easily acknowledge that a behavior is problematic and can make a commitment to correcting it. Now, at this stage, there is an acknowledgement that the pros of the change behavior outweigh the cons. During the action stage, change actually happens. Total abstinence of an adverse behavior, like smoking or drinking, is the expectation for a period of fewer than 6 months. While in this stage, people gain confidence as they believe they will have the willpower to continue on the journey of change. Continuing the new behavior change is the focus of the maintenance stage. Here, individuals have maintained total abstinence from an adverse behavior for more than 6 months. As people progress through this stage, the more confident they become in their abilities to sustain positive choices for their lifestyle. And they're less tempted, and they're also less afraid that they may relapse. The whole goal of the trans-theoretical model is actually to make sure that people maintain those positive health behavior changes throughout life. We, as public health practitioners, can actually help them, and we do this through health promotion and health education. Health education is defined as any combination of planned learning experiences in which theory and evidence-informed practices are used to provide equitable opportunities for the acquisition of knowledge, attitudes, and skills that are needed to adapt, adopt, and maintain healthy behaviors. This works in conjunction with health promotion. Many health promotion programs have a component of health education that is very important because it's the way that we can get people to move from one stage of change to another. Health promotion is defined more broadly as any planned combination of educational, political, environmental, regulatory, or organizational approaches that support actions and conditions of living that are conducive to the health of individuals or communities. Both health education and health promotion actually involve primary, secondary, and tertiary prevention. Primary prevention is actions and interventions designed for individuals or populations to identify risk and reduce susceptibility. As a reminder, secondary prevention detects and treats disease in early stages, like screening for cancer. And as we've discussed before, tertiary prevention alleviates the effects of disease or injury. So this is somebody that has been injured that goes through rehabilitation. There are a couple of assumptions that are really important to understand because they become central to health promotion practice. And if we understand them, we can move forward with confidence, and we know that our work will actually lead to better health outcomes. We cannot expect people to adopt lifelong health-enhancing behavior if we don't use science, if we're not uniform on our approach, and if we're overbearing. We also can't expect people to change behavior just because we introduce them to health education or a health promotion program. These assumptions that we need to be mindful of when we're trying to change behaviors are that health status can be changed. Behavior can be changed, and those changes can influence health. Initiating and maintaining behavior change is complex and difficult. Before behaviors can change, the determinants of behavior, the nature of the behavior, and the motivation for the behavior must be understood. Individuals must also be ready to change. Health is multidimensional and is determined by fluid interactions between individual behavior, social factors, biology and genetics, health services, and policymaking. Successful health promotion efforts tailor interventions to the unique characteristics of a priority population, which the definition of that is a group or subset of a group of people who are the focus of an assessment or an intervention due to identified common characteristics. To further your introduction of health program planning, we're going to talk about a few people that are important to health program planning and also go over what's known as pre-planning. This will be very helpful in terms of your discussion this week. There are actually people that you may meet if you work in a health department that are known as health education specialists. And these people are identified as an individual who has met at a minimum a baccalaureate level of health education in their academic preparation. These individuals are key when it comes to program planning. but it doesn't mean that they're the only individuals that do health program planning. As we know it today, health education has evolved partly through scientific method, partly through trial and error, and more generally through collaboration with many different people. Other people to know about, we've discussed in past sections, are actually stakeholders. Stakeholders, again, are any person, community, or organization with a vested interest in a program. Good planning keeps these individuals notified and gets feedback from these individuals. The planning process should not be secretive or mysterious, and we need to make sure that the planning is empowering. When we talk about health program planning, there's several responsibilities to this. It includes planning, implementation, and evaluation. A lot of times, most successful health program plans use what is known as pre-planning, which allows a core group of people or a steering committee to gather answers to key questions that are critical in the planning process before actual planning begins. Also, before starting the actual planning process, planners need to have an adequate understanding of the community where the program will be implemented. Community is a collective body of individuals who share commonalities. When we are doing pre-planning, we need to consider the following questions. We need to make an assessment of needs and capacity. This is data collection and analyses to determine needs and capacity in order to set priorities and select a priority population. We also need to consider our goals and objectives. These are statements that outline what we are going to accomplish. We need to consider different interventions. These are strategies and activities used to achieve the goals and objectives. Then we can implement, which is carrying out strategies and activities, and then we can evaluate, which is actions that are used to determine the effectiveness of the intervention and improve the quality of the program. When we talk about wanting to pre-plan, we think about all these different areas. And while we might not have an answer, it's really important to consider some questions. Who is the priority population? How are we defining community? What are the desired health outcomes? Does the community have the capacity? Is a policy change needed? Are environmental changes needed? Is it inter or intra-organizational? Who are the partners? What is the time frame? What kind of program documentation or justification is needed? What authority will planners have? How will the planners be organized? What is expected of those that participate? How will partners be selected? How will programs be tailored to a priority population? How will we engage this population? Will the planning process use a top-to-down or bottom-up approach? How are we going to identify and secure resources? Will we need contracts or MOAs? While you're not going to have all of the answers to those questions during a pre-planning process, it's important to at least consider them and maybe have multiple answers for each of the questions. Here are the references for this PowerPoint.